Hello, dear colleagues. This is a mature cataract. 2.8 millimeter main incision is made at 11 o'clock. A paracentesis incision is made at 8:30 o'clock. A big air bubble is injected in the anterior chamber. Now trypan blue dye is sprayed over the anterior capsule of the mature cataract. Viscoelastic substance is injected into the anterior chamber, and another paracentesis incision is made at 1:30 o'clock. Now the anterior capsule is incised with a 26 gauge bent cystitome, and we can see that milky fluid has come out. A ureter forceps is used to make a very small rhexis at this stage, because if we try to make a larger rhexis at this stage, there is a chance that the rhexis will run into the periphery underneath the iris, and it will be very difficult to retrieve the iris. Now milky fluid came out because there was high intralenticular pressure. This pressure is decreased by aspirating some superficial lens matter with the help of a direct Simcoe cannula or bimanual IA. As soon as we remove some superficial cortical matter and decrease the intralenticular pressure, the character of the cataract totally changes, and when we enlarge this small rhexis, it does not tend to run into the periphery. Now a Vanna scissor is taken and a small cut is given at 8 o'clock of the mini rhexis margin. Ureter forceps is again taken, and the capsule is guided in such a way that the rhexis is enlarged and an optimum sized rhexis is achieved. We have got a fairly good capsulorhexis, and it is of about 5.5 to 6 millimeter diameter. Viscoelastic substance has been injected again, and now I go into the anterior chamber with the tip of the phaco handpiece. The titanium tip is embedded into the nucleus, and this is the first chop, and we get a complete crack. This cataract is mature, but it is not very hard. It is rather quite soft. At this time, the phaco power is 60, flow rate is 45, and vacuum is 450. So the nucleus has been removed. Now there is a small piece of nucleus at the side port at 1 o'clock, 1:30 o'clock. It has come. Now is the time to remove the cortical matter which is there in the equator of the capsular bag. This is a 23 gauge direct Simcoe cannula. This is a very simple instrument, but it is very useful. Just remove all this superficial cortical matter This is a very thin 23 gauge Simcoe and it goes through the side port very easily. The cortical matter from 12 o'clock, 11 o'clock, 1 o'clock are removed. In this case, there is no cells sticking to the posterior capsule and the posterior capsule is very clear. 2% SPMC is again injected and hydrophobic acrylic aspheric intraocular lens is implanted inside the capsular bag. A Sinskey hook is used to dial the intraocular lens and place it at a desired position. Now is the time to remove the viscoelastic substance. This is the direct Simcoe cannula. Again, at this time I am flushing out the viscoelastic substance from the front or now from the behind of the intraocular lens, and almost 90% of the viscoelastic substance is removed by the Simcoe cannula. Now I use bimanual IA to remove the viscoelastic substance thoroughly. I do not want any rise of intraocular pressure in the postoperative period. Now the side ports are hydrated and antechamber is formed with BSS. A final wash is given with BSS and the antechamber is formed. Thank you very much for watching.